Hi, this is Brian Kim. I'm going to share with you case number 278 in the Best Way to Do Cataract Surgery series. And the title of this series is not to suggest this is the best and only way, but to get you to think critically of your technique so that you can provide the very best for your patient. So this is a patient with a small pupil and dense cataract. And you know, when I deal with small pupils and dense cataracts, I'm worried about zonulopathy. So I always place iris hooks in these situations. I'm going to use Trypan blue as well, and then perform terminal chop and cross chop techniques and mechanical fracturing techniques. So you can see the Veritas overlay. The cool thing about this overlay is customizable as far as how and where you want the different components located. You can see this is the small wire speculum, but due to this patient's very heavy brow, I'm going to use the asymmetric speculum. This is the right eye. As you can see, by having the wider blade at the bottom, this enables preferential retraction of the upper lid with the heavy brows. This is the corneal marker, which will help me to center and size rhexis. And this is the 1mm diamond blade. I make my first incision, which is going to be subincisional through the sclera and the conjunctiva. And then I'm making these other incisions, 4 more incisions for the iris hooks, and then 2 incisions for the cataract surgery, inferiorly as well as superiorly. You can see this patient has a strong Bell's reflex. I'm using the cotton tip to try to control the eye, pushing the eye down so I can make my other incisions. I'm trying to ask the patient to look down. And then finally the patient looks down. I'm able to immobilize the eye with the cotton tip and then make the final incisions. This is some intracameral epinephrine. And then I like to start with the hooks before I put viscoelastic in. Why? Because if you push viscoelastic in first, it's going to push the iris plane back, and it's going to be much more difficult to hook the pupil edge with the iris hooks. So that's my pearl. Always put the iris hooks first before you put in the viscoelastic. I like that subincisional scleral incision. And why? Because I can make my main incision right over that incision, and I will not have any iris prolapse by doing it this way. And you can see I have a very efficient way of placing the iris hooks. You just find the spot, slide it in, pull the stopper back, twist the hook, and then engage the pupil, and then pull the stopper back down. Fairly efficient way, and most importantly, a customizable way. You have much more flexibility, versatility, by using iris hooks rather than a ring. And I prefer using 2 instruments to do these maneuvers. And this is the final hook, pulling the stopper back, and then sliding it into the incision, pulling the stopper back some more, engaging the edge of the pupil, twirling it, and then cinching it down. This is some Trypan blue and then some air. Pushing some more Trypan blue. Going all the way contra-incisionally, pushing the air as well as the Trypan blue out of the incision. And this is a 2.4mm blade. I make a vertical groove, place the blade into the deep part of the groove tunnel, and then I enter. With the same dispersive viscoelastic cannula in the left side paracentesis incision, it helps me control the eye, minimizes the Bell reflex. So I always like to have a second instrument whenever I do these types of maneuvers. It just gives me excellent control. And I already have my instrument in the eye anyway, so might as well keep it there. And then if I have trouble, I can also push some more viscoelastic. To me, minimal wasted movements when it comes to cataract surgery is really the key to efficient surgery. This is the microrhexis forceps, the sharp tip microrhexis forceps. Puncture the center, pull down, and then going around circumferentially. You can see I have excellent chamber control. And then because I have that cannula, I also have control of the eye. It's not moving around side to side or up and down. And that's because I'm immobilizing the eye with the cannula. Again, passive fixation with the cannula. Finish off the rhexis. And this is the capsule fornix hydrodissection technique. I place a cannula under the rhexis edge contra-incisionally, point the tip down, get a nice wave, lifting the lens up, decompressing the bag, and then the lens begins to spin. Turning on infusion, adjusting the tip, just pulling that little piece of that capsule out of the way, and then burping some of that capsule out. Lifting the incision with the chopper, going in with irrigation off to minimize Descemet's trauma. The Veritas has excellent chamber stability. I remove the surface epinuclear material, and then I start sculpting. This is the peristaltic mode. The cutting efficiency of the machine is excellent. This cuts through even the densest lenses without any difficulty whatsoever. Very efficient cutting for sculpting, as well as during the chop and lens disassembly portions of the case. Rotating the lens 180 degrees and doing some more sculpting. And then going bevel down, placing the chopper around the equator contra-incisionally, pulling the chopper towards the center. That's the terminal chop maneuver, bisecting the lens in half. Placing the chopper under the right heminucleus, pulling it centrally toward the phaco-tip and fracturing the lens against the phaco-tip, and that is a cross-chop maneuver. Placing the chopper around that first quadrant, pulling it centrally toward the phaco-tip and fracturing the lens once again, and then using mechanical forces to crush the lens into smaller pieces, and then emulsifying the lens pieces. So again, this is a peristaltic quadrant mode. You can see on the right side the aspiration and vacuum, and you can see I only engage the aspiration and vacuum when it's time to emulsify the lens pieces. Otherwise, when I'm trying to break the lens pieces, you can see those components just drop to zero. So as I'm fracturing the lens pieces using mechanical forces, those components, the aspiration, vacuum, and ultrasonic energy drop. I fracture the lens with mechanical forces, meaning I manually crush the lens piece with the chopper and phaco-tip using my hands rather than using the machine. By doing it this way, I minimize any potential risk to the eye, because sometimes, the fluidics can move very fast. And so by crushing the lens using my fingers, as I'm crushing the lens into smaller pieces, this is just a very controlled way to break the lens down. And then when I'm ready to remove the pieces completely, you can engage the Veritas and emulsify the lens pieces very efficiently. Now, this is one of the earlier cases using the Veritas. As I've used this machine more and more, I've become much more bold in using the ultrasonic energy in these dense lenses. Why? Because it's very efficient. The dispersive viscoelastic, the endocoat, does such an exceptional job at coating the endothelium. And so even though I use a lot of ultrasonic energy to eat up the pieces very fast, post-op day one, these corneas are crystal clear. And so as long as you have good coating of the corneal endothelium, you can really be more aggressive with emulsification. And again, in these cases, I'm much more ginger because I'm utilizing the mechanical fracturing concepts that I've always advocated for on my channel. But again, as you see more and more cases into the future, and if you look at my cases that I'm doing now, because this case was recorded several months ago, but if you look at the cases that I'm doing now, I'm much more aggressive with using the ultrasonic energy, and I feel very confident that the corneal protection is really, really good with this viscoelastic and this machine. Push some more endocoat into the eye. Again, just being safe and trying to be as gentle as possible. And then now I'm manually crushing the lens between the phaco-tip and the chopper. And then when I'm ready, more aggressive with the pedal and eat up the pieces. Getting the piece on the tip with some vacuum and then crushing it with the chopper. And then eating the remaining pieces. Being careful to shield the posterior capsule from the phaco tip. And that's it. So I take the chopper out, push BSS in, take the phaco tip out, and then I go in with the eye and handpiece. But before I do that, there's a little fragment there. So I eat that fragment, making sure I keep the cannula rather deep so I don't accidentally have the posterior capsule come up. So I take the phaco tip out, and then I go in with the eye and handpiece. I start sub-incisionally removing the cortical material, sweeping side to side, trying to loosen up the sub-incisional cortex. You want to be very careful with the metal tip. Even though this is a great metal tips are metal tips, you have to be very careful. Going around, sweeping side to side, loosening up the cortex. This machine is really very efficient, moves very fast, and like any machine that's high performing, you just have to be very respectful. And you have your settings like I have, is very aggressive. You have to be very cognizant of not being too aggressive and using foot pedal control to your advantage. So you have excellent control of the eye throughout the case without having any trouble. Now all the cortex is removed. I'm going to use the BSS cannula to pulse the subincisional area, looking for any small wispy pieces of cortex. It looks pretty clean. Turning off infusion now. And then I push the cohesive viscoelastic to fill the bag. And you want to turn off the infusion, otherwise the viscoelastic is going to come straight out because the infusion will push the viscoelastic out the main incision. So you always disengage the irrigation and then you push the cohesive viscoelastic into the bag. And this is the Singer Coke sweeper. I'm sweeping the underneath side of the anterior capsule. And then going through the other side, sweeping underneath the anterior capsule again, polishing and removing any lens epithelial cells. Using the cohesive viscoelastic cannula, I'm controlling the eye from the Bell's reflex and then advancing the lens. As I see the chamber collapsing, I push more cohesive viscoelastic to fill the bag, and then I deliver the lens. With this lens, I prefer to use the cannula that I already have in my hand to disengage the haptics from the optic. This lens is a little bit stickier than the Acrosoft lens I was using before, and so it's important to be able to disengage the sticky haptics from the optic, and using the cannula is just so much easier than trying to push it with the eye and handpiece. You can see how efficiently I'm able to disengage the hooks from the pupillary edge. You just, using a two-handed technique, pull the stopper back, twirl it, and then disengaging the pupillary edge and then pulling out the iris hook. Very easy. And again, the best thing about iris hooks, it's customizable, it's titratable, much more versatile than using a ring. So that's essentially the end of the case. I'm going to go underneath the lens, removing all the viscoelastic from within the bag, repositing the lens back down, sweeping underneath the rexus edge. I'll remove the viscoelastic from the anterior chamber, and then I'll hydrate my incision. So again, this is a patient with a dense lens, small pupil. In my mind, dense lenses and small pupils equals the potential for zonulopathy. In that context, I am not so bold as far as trying to do direct chopping in that situation, knowing that the zonules might be a little bit weaker. And so visibility is pretty important in these situations. So I placed 5 iris hooks. One of them was subincisional. And why do I do that? Because this helps eliminate iris prolapse, because that subincisional iris hook retracts the iris so that it just can't get caught into the incision. And then I put Trypan blue in, and then of course did my rhexis. You can see the micro rhexis forceps are just phenomenal, great control. And then I performed the terminal chop, cross chop. You can see the cutting efficiency with Sculpt is fantastic with the Veritas. And then the lens emulsification, removal of the lens pieces is very efficient. Again, I'm so used to crushing the lens with the instruments because I feel like that provides the best protection. But again, this machine is so efficient. The endocoat does such a good job in protecting the cornea. More recently, I've been a lot more bold with my ultrasonic energy. And again, that's because I know the cornea is well protected with this viscoelastic. And because the efficiency of lens removal is just superior, I mean, it just eats up the pieces so fast. This is the definition of the modern phacoemulsification machine. So I hope this was helpful to you, and I thank you for your attention.